We're now going to talk about endocrine disorders and the treatment of diabetes, and the information is in Chapter 66. Hopefully this is review for you. We're going to start with insulin therapy. Insulin is going to mimic the endogenous insulin that our pancreas normally produces, and it acts as the gatekeeper by helping transport glucose into the cell. Insulin treatment is given for patients with type 1 diabetes, gestational diabetes, and for type 2 diabetes. There are different types of insulin, and they have variable onset, peak, and duration. So you have your rapid duration, short duration, intermediate, and long. Kind of depending on each situation with the patient, they will be prescribed a combination of these or one of these. It just varies based on what is happening with them. Insulin can be given either IV or sub-Q. There's actually now inhaled forms of insulin available. And in emergencies, insulin is given kind of similarly to a continuous infusion. It's mixed in a bag of normal saline and run through the pump if there is a condition where the patient has extremely high blood sugars. There are certain diabetic conditions that we'll talk about in 206. You will see insulin pens being used. That's an easy way to administer insulin. You turn the dial to the appropriate dose and then deliver the dose with a tiny little needle. You might also see patients with type 1 diabetes with implanted pumps, delivering a consistent amount of insulin to mimic the pancreas as much as possible. And keep in mind, too, that insulin therapy is used for other reasons. Regular insulin is used in non-diabetic conditions, such as stimulating growth hormone secretion, and is also used for the treatment of hyperkalemia. Insulin actually helps to move potassium into the cells. And so what that does is it drops the serum levels of potassium. So that's kind of a non-diabetic indication for insulin therapy. I don't expect you to memorize what the durations are and the onset and peak. I just want you to kind of keep in mind what the rapid insulins are, the Novolog and the Humalog, what the short duration ones are. That's your regular insulin, Humulin R, Novolin R. Intermediate, there's really only one type. It's NPH. You might see Novolin N or Humulin N. And then we have our long duration insulins, which are the Lantus and the Levemir. Those are your main categories, main types. You'll see a lot of other different names, and there's more and more that are being developed all the time. But these are kind of the big main ones for you. So with insulin therapy, just a few reminders about considerations in administration and storage, mixing. It's best to rotate through injection sites when you're administering insulin. Those sites are the abdomen, the upper and outer arm, the buttocks, and the front or sides of the thighs. The best absorption location is the abdomen. Insulin can be stored at room temperature or in the refrigerator. You want to avoid extremes of temperatures. You don't want freezing, or you don't want extreme heat or direct sunlight. Check expiration dates. Make sure the expiration dates are valid and you're not using beyond the expiration dates. Insulin is good for about 28 to 30 days, so roughly a month. Make sure that you don't have any clumps or little pieces of the medication that are floating around in the insulin vial. If you do, you want to throw it away and get a new vial. You want to make sure that there are not any little clumpy things happening in there, because there might be a problem with the drug itself. So with mixing, NPH, the intermediate type of insulin, can be mixed with short or rapid acting insulins. Remember the rule of clear to cloudy when you're drawing those up. You do not mix the long-acting insulins, so no Lantus or Levemir. You will not mix any of the long-acting with any other types. And then for adverse effects with all insulin, you're worried about hypoglycemia if there's too much insulin given. And so we're looking for those signs of hypoglycemia, weakness, cold, clammy skin, shaking, hunger, mood changes, dizziness. And if you suspect hypoglycemia, you always want to check the blood sugar and see where the patient is at with that. And we consider hypoglycemia anything kind of around 60 milligrams per deciliter or less, kind of in that range. So you might see some people experience symptoms of hypoglycemia at a higher level, and you might have some patients who don't show signs of hypoglycemia until their blood sugars are extremely low, like the 30s or the 40s. So there's some variation there, but you always want to check their blood sugar if they're demonstrating signs of hypoglycemia. You also are concerned a little bit about injection site reactions, especially if the patient's using the same location over and over. That's why we rotate through the injection sites to help with any of those reactions. And there's also the potential for rebound hyperglycemia. This can happen in the morning. This is also called Somogyi phenomenon. This is where the patient actually experiences a drop in blood sugar or a hypoglycemia episode in the middle of the night, and then in response to that, the body increases the blood sugar, and by morning, they have a very high blood sugar. So that is the Somogyi phenomenon. Okay, now let's talk about glucagon. Now remember that glucagon is used for the emergency treatment of hypoglycemia. So like I just said, hypoglycemia can be considered anything less than about 60 milligrams per deciliter. Also, you're looking for the patient being in a state where they cannot eat or drink anything, or they might be unconscious, or NPO status. So those are kind of your indicators for glucagon if they cannot have anything by mouth. So what glucagon does is it stimulates the breakdown of stored glycogen, so glycogenolysis, and it's going to increase the amount of glucose that's produced, or gluconeogenesis. And it's given IV, IM, or sub-Q. And some adverse effects from glucagon can be nausea and vomiting and hyperglycemia. So you can actually, by treating the hypoglycemia, cause hyperglycemia, and then you're having to treat that once you've given this drug. The other name that you might hear being used in place of glucagon is dextrose 50%, and this is just another form of glucagon that is given IV in emergency situations to treat hypoglycemia. Okay, patients with type 2 diabetes have a certain degree of insulin resistance and decreased insulin production. And so type 2 diabetes makes up for approximately 90% of patients with diabetes. Patients that are type 2 diabetics are treated with oral anti-diabetic drugs. And here are the list of the 6 categories of oral anti-diabetic drugs that we'll talk about. They may also need insulin therapy in addition to the oral drugs. So that's common to see in patients with type 2 diabetes. And we're going to touch on all the different categories here. Hopefully this is, again, a review a little bit for you. So your first class are the sulfonylureas, and your main drug is glyburide or diabeta. This is the second generation drug that is going to stimulate the release of insulin from the pancreas. It's going to stimulate the beta cells. So it does rely on some functioning of the pancreas and some functioning of the beta cells. The other thing it does is that it improves insulin binding to the receptors. So it's going to decrease some of that resistance that happens in type 2 diabetes. Your major adverse effect is hypoglycemia, and that is because it's stimulating that release of insulin from the pancreas. So hypoglycemia can definitely occur with this drug. The chemical makeup of sulfonylureas is similar to other sulfa drugs. So if the patient has an allergy to sulfa, this is probably not the best option for them. Type 1 diabetes, as well as patients that have DKA or diabetic ketoacidosis, are contraindicated for this drug type because the only effective treatment for these two conditions is insulin. They cannot use this drug or any oral antidiabetics for that matter to treat those conditions. They have to have insulin therapy. Alcohol does, in combination with glyburide, can cause either hypoglycemic or hyperglycemic effects in the patient. So it's something to educate patients about. Our next group is the biguanides, and our main drug is metformin or glucophage. And biguanides are a good option, especially for children who might have type 2 diabetes or are kind of headed that direction. Children that are 10 years or older can have metformin. This drug has multiple formulations available. It rarely causes hypoglycemia because this drug isn't stimulating the pancreas to release insulin. It's decreasing reabsorption of glucose in the GI tract. And so the effects are mostly GI related. It's also going to reduce the amount of gluconeogenesis that's occurring. So your adverse effects you are going to expect are related to the GI tract: nausea, vomiting, diarrhea, also decreased appetite, decreased absorption of vitamin B12 and folic acid. And in rare cases, this can cause lactic acidosis. For whatever reason, metformin can increase the lactic acid production in the body. And this is especially true in patients with liver and renal disease. This drug is also contraindicated in patients with renal impairment. It can build up to toxic levels in patients that have renal impairment because it is excreted in the kidneys. And we have to be concerned about the use of IV contrast dye. So patients that are using metformin should not be given IV contrast dye for procedures such as CT scans around the same time. So there's about a 48-hour time frame before and after contrast when the metformin should not be given. And the reason for this is that it causes more renal dysfunction or deterioration if the two are in combination with each other. So we have to be really aware of what is happening with our patients if they're going down for any special procedures that require IV contrast dye, and if they're on metformin at the same time. Glutamides is our third class. We're paglinide. Prandin is our main drug. This drug is very similar to the sulfonylurea drugs. It's stimulating the release of insulin from the pancreas. It's stimulating the beta cells in response to food. And this one is nice because we can use it in patients with renal insufficiency because there is no renal excretion happening. So this is one of those that we can use in patients that have renal dysfunction. It can cause hypoglycemia. Again, that's related to the stimulation of insulin being released from the pancreas. We also want to use some caution on hepatic impairments because it is metabolized in the liver. And again, it's contraindicated in DKA and type 1 diabetes because these patients have to have insulin to treat those disorders. And our fourth category is the thiazolidinediones, or TZDs. Rosiglitazone is the prototype of Vandia. These work by increasing cellular sensitivity to insulin, so that insulin resistance that occurs in type 2 diabetes, it's going to help decrease that, and it's going to help the cells use that blood glucose for energy. It's also going to decrease the amount of gluconeogenesis that's happening. The effects do take some time. It may require about 3 to 4 months to see the optimal effects of lowering the blood sugar in patients that use rosiglitazone. The other interesting thing about this drug category is that it causes an increased amount of fluid retention. So adverse effects are edema. You can also have macular edema and increased lipid levels. And we have to use caution for our patients that have increased lipids already. And because of the increased fluid retention, this drug can worsen heart failure. And so that's another population of patients who should not be on this medication. The patients that have heart failure or fluid retention already happening. And again, this drug is contraindicated in DKA and type 1 diabetes. Moving on to number 5, the alpha glucosidase inhibitors. Our main drug is acarbose or Precose. These drugs are going to block alpha glucosidase enzyme that's responsible for carbohydrate breakdown. So these work by keeping the blood glucose from creeping up too high after a meal. So they're delaying the absorption of dietary carbohydrate in the GI tract. So your major effects are, again, GI related because this drug is working in the GI tract. So diarrhea, flatulence, and abdominal distension are your big GI adverse effects. It is contraindicated in patients that have GI disorders or diseases such as inflammatory bowel disease, bowel obstructions, a predisposition for bowel obstructions, and colon ulcers, those types of GI problems. The only way that this drug can cause hypoglycemia is when it's paired with other oral antidiabetics, but by itself it cannot cause hypoglycemia. Okay, our last group, our last class are the incretin enhancers. There's actually 2 drug classes within this group that enhance incretin action. And we're going to talk about just one type, the DPP4 enzyme inhibitors. So normally DPP4 enzyme blocks the incretin hormones and are increased in the small intestine in response to meals. So by blocking the DPP4 enzyme, the incretins increase and they are going to do some beneficial things in the small intestine. They're going to help decrease blood glucose levels by increasing insulin secretion. They're going to decrease glucagon secretion, and they're going to delay gastric emptying and help the patient feel fuller longer after a meal occurs. So kind of some multiple effects of the incretin enhancers. Adverse effects really are minimal with sitagliptin, Januvia. There are not many adverse effects, which is a huge bonus with this drug class. There is the possibility for an increase in DIG levels if patients are taking digoxin already. And again, contraindicated in DKA and type 1 diabetes because these drugs, again, cannot be used to treat those conditions. And that wraps up the different oral antidiabetics. So in summary, we know that the diabetes medications are prescribed based on specific needs of the patients, taking into account their health history, their health problems, pre-existing conditions that they might have. Some of these oral antidiabetics work well for other types of conditions, such as patients that have increased lipids or increased cholesterol. Combination of drugs are used many times for added effects. So you will see a combination of some of these oral antidiabetics used to have a better therapeutic effect of lowering blood sugars. Patients really need to be educated about diabetes. In addition to being on these medications, what else are we teaching the patients? Of course, we want to stress the importance of a diabetes diet and also the importance of exercise. And then the long-term management of diabetes, we have to remember that along with the medications, we're also monitoring their hemoglobin A1C to see long-term how they are doing with their diabetes, and are we hitting their glucose targets for those times during meals, before meals, fasting, and bedtime. Are they hitting the the acceptable ranges for diabetes. Those are all important things to ensure that your patients don't end up with complications down the road from their diabetes. And that wraps up our information on exam 6. Let me know if you have any questions. Thanks.